Dr. Kirsky,
in the U.S., when I do therapies, I usually use moderate doses, or 3 millicuries per kilogram, around that. So that can be done as outpatient. And anywhere in our institution, which Memorial Sloan Kettering, our own internal policy is that more than 250 we hospitalize, less than 250 millicuries we give instructions, and the patients can go out as outpatients. And as long as we decrease the radiation dose to the caregivers or the general public to less than 500 and less than 100 MR, then we're allowed to do
Oh, it's interesting. I mean,
outpatient.
The regular, and I'm interested that you're actually rather liberal in the States, because normally my feeling is in North America you're really rather frightened of nuclear medicine generally. I can now give a standard dose of 200 millicuries, plus or minus, and they're only allowed to leave when the Geiger counter has a certain emission rate. So it's usually about 3 days in the hot room. But it's not terrible. They have a TV, books, everything else. And you can still go and visit them. But it all looks rather intimidating. Yeah.
I've had one treatment with MIBG which was successful in its application to encapsulate a tumour.
Yeah.
I actually experienced it at UPenn, and I believe I'd corroborate what's just been said. I was released into the general population very quickly, but the Geiger counter approach sounds very, very sensible. I'm interested in the potential carcinogenic effects of these treatments, particularly when this conference seems to have indicated a strong prevalence towards secondary cancers.
Yeah.
And both with this kind of treatment, or these kind of treatments, and also with phenoxybenzone, long-term use of which is, some people would suggest, carcinogenic.
Phenoxybenzone?
Yes.
Not to my knowledge.
Is it not?
Any? No. No, I don't think that is. The MIBG, it's actually a very perceptive point. It was one of my colleagues recently who pointed out that a number of our patients, some years after MIBG, had developed myeloproliferative diseases, leukemias, lymphomas, myeloma. It's only a small number. And we're actually in the process now of tracing back all the patients we treated over the last 20 or 30 years. Now, quite a few of them had very nasty progressive paragangliomas and are no longer with us. It remains, I think the short answer is there is no evidence that it forms second cancers. The longer answer is we don't know. And I think it's an open question.
Just to follow through on that,
yeah.
The obvious thing as a patient is to then ask, if you're using Geiger counters, it does sound a little bit strong. And is there any deleterious effect?
No. Let's see it in context. For example, we treat a lot of thyrotoxicosis with radioactive iodine. Huge series, 10, 20, 50,000 patients followed up over prolonged periods of time. And again, in some cases, these patients require to be admitted. No evidence of any long-term deleterious effects. Thyroid cancer, we use quite large doses of radioactive iodine. Patient in our centre is kept in for 3 or 4 days. Again, absolutely no evidence of long-term second cancers. So I think it may sound frightening, and people have various feelings. I might offer radioiodine to a patient with Graves' disease or thyrotoxicosis, and they jump up and down and say, "Oh, no, I'll glow in the dark. I don't want to do that." But I think on the whole, it does seem to be remarkably safe. But yes.
There's quite a long experience since the 80s with MIBG, and the experience is in pheochromocytoma and neuroblastoma predominantly, and then also in carcinoid. So I think that the numbers are probably less than 5% incidence of myelodysplasia. So when I do it, I tell my patients that there is some incidence there. Whether that's greater with when you do chemotherapy, like with thyroid cancer therapy, there's not much incidence It's either, some studies find a low incidence of second cancer, some find none. So it's small. For I-131 radioimmunotherapy, which is somewhat similar, there is, again, less than about 5% incidence of myelodysplasia when combined with chemotherapy. And the only study that was done just radioactivity alone, the incidence was, well, they didn't see any with radioactivity, but when combined with chemotherapy, there can be.
I have a question. In France, we use prazosin, and we begin with very low doses for patients, but sometimes even with very low doses, they do not tolerate the drug, basically because of drop of blood pressure when they stand up. Yeah. And so how do you do that?
Prazosin is a pretty horrible drug, and I don't know why it's so different, but it's short-acting, and as you say, you have to titrate the dose upwards. Doxazosin, I've just found very, very few problems. I usually start with 2 milligrams or even 4 milligrams of the long-acting formulation once a day, and very few patients seem to have any problems with that. I've used terazosin, I think, once or twice. But yeah, you're right, prazosin has got a bad record, and particularly in routine hypertensives. Yes?
You know, the preoperative management guidelines are very, very institution-specific. And it's very hard to change the way people do things. And then there's also a problem that some of these drugs are not available.
Yeah.
I don't have enough data to present to you at a meeting, enough patients, but I've pretty much gone to a stepwise therapy.
Okay.
When I can get metyrosine, that's the best drug.
Really? Okay.
Especially from my viewpoint,
Yeah.
which is what happens during surgery and in the post-op period. And also, as far as patients, telling patients symptomatology before, they feel much better with that. You take it almost to where they begin to have symptoms, you drop back, then you add the next drug. So I usually start out with metyrosine, paper by Kirolpachak. Actually highlights very well. Then add doxazosin.
Right.
I begin to get symptoms, drop back a little bit. I add the beta blocker, drop back a little bit. By that time, I've gotten 5,000 phone calls from the patient. They're in the hospital. And then I get my echo before, give them their fluid and operate on them the next day. But
I suppose I try and avoid the 5,000 phone calls.
That's the problem with that kind of therapy, is that you have to do that. You can actually make patients have very few symptoms and really lead pretty normal lives. And I don't believe it is hard, other than personal experience, to have patients have a lot of the postural hypotension. I think you can have very adequate intraoperative blood pressures and less post-op problems, even with systolic blood pressures in the 110, 120s. I don't think you need to get them into the 90s and this kind of thing as we used to do.
Well, what I do is I admit the patient for 2 or 3 days, start the phenoxybenzamin, titrate their blood pressure against the phenoxybenzamin, and then treat them as an outpatient. And if they're doing 110, 120 systolic, absolutely fine. And then obviously they volume expand and gradually improve. You're absolutely right, it's very institution specific. So in my old place, which I left 6 months ago, we then brought them in for 3 days before their operation and gave IV phenoxybenzamin each of those 3 days. We never ran into any problems. In my new place, they absolutely refused point blank, we don't do this here, and they just came straight in. They then give them intravenous dexamethasone, the rationale for which I still can't quite understand. It does sort of mess up their adrenal cortex. And they seem to have had a reasonably good record. I suppose, if it works for you and you're happy with it and you haven't had any major problems, might as well just carry on. I think most of us are quite conservative.
The phenoxybenzamin, the problem really with it post-operatively is the huge, I mean, I can really tell you the difference, the amount of fluid you have to give after the tumor removal, because most patients will have vasodilation, especially, and you have to give a lot of fluid. So then these patients, you can have pulmonary edema really iatrogenic.
Yeah.
And of course, a lot of this also means there's some cardiac function. It's not always what you think it is. You think they have a good heart, but really don't. They can't tolerate these fluids.
We're doing...
They go into heart failure after surgery.
We actually have a research protocol now, so all of our patients get cardiac MRI and cardiac NMR as well, preoperatively, to assess their function. Yeah, okay.
A patient who just happened to be a distant relative of mine who had a pheochromocytoma was complaining of the post-operative blues after the tumor was removed, and he had been on alpha-methyltyrosine. And I told him that, speaking as a chromaffin cell biologist and not pretending to be a clinician, I would recommend strong coffee. And he used strong coffee. It's a good drug, it's short-acting, and it had a miraculous effect.
It's available intravenously.
Oh, it's much better per aura, they say.